Hi, everyone. Welcome to this webinar. Uh, Thank you for being here with us today. My name is Marian Fonica, and today we are going to talk about intraoral scanning, about the challenges, and especially about managing the tissue, stopping the bleeding. I will leave this slide for those that cannot hear me. As a disclaimer, I'm an endodontist. I'm from Romania. My conflict of interest it's with one company with Centrix because I'm a medical educator for this company for EMEA territory, for Europe, for Africa, and for Middle East.
Hello, everyone. My name is Cristian Nechescu. It's a pleasure to be here, and thank you very much for the invite. I'm a general dentist. I work together with Marian in the same office, and my main focus today in my office is prosthodontics and restorative dentistry. And for today, I will show you some of my cases and the challenges and the management of these challenges with intraoral scanning.
So usually we are working together. I'm an endodontist. I'm treating the teeth, and my colleague will restore them, usually by prosthetic means, sometimes by extraction, depends on the tooth. So for for your colleagues that are working already with the intraoral scanner, you know that the bleeding is the worst enemy of any optical impression. Every time when you have just even a small bleeding, the intraoral scanner cannot read that. So the first thing that you have to do is to stop any bleeding, to obtain a dry operating field, because even the presence of the cervicular fluid can influence the reflection, can influence the accurate reading for the intraoral scanner. Because with a classical impression, it's easy. By the pressure that you're applying with the impression material, you actually can additionally push the gingiva and obtain even more detail. With intraoral scanning, what you see, it's actually what you get. So in the first place, you want to have a clean and dry operating field. Usually, we are obtaining the clean, dry operating field by using the retraction cord. The retraction cord is still considered the golden standard in dentistry. And the main reason why you want to put a retraction cord or some alternatives will be to stop any bleeding. You want to open the sulcus, so you obtain more deep and accurate impression, no matter if it's an analog or a digital impression. And you want to have a dry operating field. Some general consideration, of course, for any subgingival crown or even for juxta crown that it's near the gingival line, you need a good retraction. The retraction cord is by far the most used material for obtaining the retraction. And you can use it with an astringent or without an astringent solution. And ideally, it's recommended to use a double cord technique. So you'll have a 00, 000 placed in the sulcus. You make the preparation, leave the first retraction cord in place. Then you are placing the second retraction cord, leave it for a while. Then you remove it, and fast you have to take the impression. The retraction cord, it has some main disadvantages. It can be, in some cases, hard or even impossible to place without breaking the ligaments. It takes a lot of time. For me, because I don't have a lot of practice in the prosthodontics, it takes a lot of time. Usually the retraction cord should be left in place between 4 and 10 minutes. That's a huge amount of time. Then you have to remove it, and you have around 30 seconds to place the wash material into the sulcus and take the impression. Otherwise, you have to redo the procedure. So, like in this case, for this canine, you see here the biological width. It's really small. You cannot place the retraction cord without break ligaments. If you want to put a retraction cord in there, you can, by putting a lot of pressure, but that will be a bad idea because you are breaking the ligaments, then you are cementing the final crown. And after a while, because the gingiva will heal, well, usually you'll end up with a permanent gingival retraction and with black margin. Or if the gingival biotype it's a thick one, you'll end up with a periodontal pocket, which is even worse in my opinion. There are some alternatives to the retraction cord. You can totally replace the retraction cord, or you can at least remove from your practice the second retraction cord. There are some pastes on the market. So you have a stringent paste which contains usually 50% aluminum chloride as astringent, together with kaolin clay to stop the bleeding and desiccate the gingiva, basically remove the water from the gingiva and lower the volume of the gingiva. When preparing this presentation for today, I read some studies, comparative studies between the retraction cord and the retraction paste. And because the retraction cord is still considered to be the golden standard, I was expecting that the retraction cord will give us a much better retraction than the retraction paste. And actually, in reality, I was surprised to see that, as you can see in this graph, the blue bar is the amount, an average amount of retraction that a retraction cord will give you. And it's around 0.65 millimeters. When you are using the retraction paste alone, you'll have around 0.8, which is huge. Actually, in reality, the retraction paste will give you a better retraction than the retraction cord. If you are mixed them together, so for example, you are using the modified double cord technique, so you are placing a thin retraction cord, and over it you are placing the retraction paste, you are not gaining much. So basically you are gaining something like 0.05 millimeters. So the retraction paste alone is better than the retraction cord. It will give you better hemostasis, it will dry the field, and it will keep the sulcus open for a much longer period of time, between 5 and 7 minutes, compared with only 30 seconds of the double cord technique. Let me show you how you use this material. So you place the material in the sulcus. So this is a modified double cord technique. You can see the retraction cord in there already placed. And take a closer look at the gingiva. When I'm applying the material, you can see the gingiva is getting instantly white because of the astringent inside. You leave it in place for 2-3 minutes, and then you are washing it with a lot of pressure. Don't be afraid, you'll not have a secondary bleeding. Yeah. So the main idea is you are still placing 000, 000 retraction cord here. Make the preparation, so you just place it to push the gingiva away, so you will not touch the gingiva with the burr. Make the preparation. After you've done the preparation, place the retraction paste, washing it, and then you are taking the impression, no matter if it's an analog or a digital impression. Let me show you how effective this technique is. So in this case, those are some provisional veneers. The patients stay for a longer period of time. As you can see there, it's bacterial infiltration. We took an initial intraoral scanning. We are cleaning the preparation with an intraoral sandblaster. And every time when you are using the intraoral sandblaster, you'll have bleeding. So we have to stop the bleeding in order to cement the veneers. I'm using here the retraction paste, leave it for 2 minutes, washing it. And now only by the naked eye, actually through the microscope, you can see the retraction. Now we are taking the second intraoral scanning. So we have one scanning before and one after using the retraction paste. We put them in exocad, overimpose them, and we can measure the amount of gingival retraction given only by this paste, which is in this case is 0.54 millimeters. So we use the retraction paste here just to stop the bleeding in order to be able to cement the veneer. If you have bleeding, you cannot cement the veneer. Otherwise, the cement will become pink and your veneer will be pink. No one will like that. In this case, as you can see, this is a preparation for a molar with the shoulder. There is a lot of bleeding. Maybe with an analog impression, you can get away somehow with this one. With an intraoral scanner, you can get no information from that preparation. You'll have a void in there. So after preparation, I'm applying the here excess edge, the retraction paste, leave it for 2-3 minutes, washing it really well. As you can see now, the bleeding stopped. You can dry it, the sulcus really well, because keep in mind you have vasoconstriction for 5-7 minutes. So there will be no additional blood coming into the gingiva and no additional fluids. Then you have all the time in the world to take the intraoral scanning. In this case, actually, we use regular impression material, so analog technique. And you can see here on the model, every dental technician in this world can see the margin of the preparation. This will be an easy job for anyone. Because I told you already how important it is this space to stop the bleeding. Of course, when you are taking an impression, you'll end up in the end with a prosthetic work with a crown or with a bridge. You want to cement that. Keep in mind that if your preparation will not have a temporary crown, or even in cases in which you have a temporary crown but will stay in place for a long period of time, you'll have bacterial infiltration. Once you have bacterial infiltration, then you have a biofilm. Every time when you have a biofilm over your preparation, there is no adhesion between the cement, and I'm referring to the resin cements. So if you are using resin cements and your preparation stay in contact with saliva more than 48 hours, then you'll have biofilm and you'll have no adhesion in there. Then you can end up with a decementation. So in this case, the story of this case is the following. The patient had a crowning here. The crown discemented. It was not done by us, but this doesn't matter. She just came into the dental office, said, you know what, I had a crown here. I don't know, I was eating something and I just swallowed the crown. I need a new crown. So this is the preparation. We took the impression, and because we didn't have a crown to start and make a direct temporary crown and bridge, and we didn't take any impression to make a temporary, when the patient came into the dental office to cement the crown, of course we have biofilm, yeah? The first thing you want to do is to clean the preparation before cementation. Doesn't matter if you are using a Profi paste or intraoral scanner, intraoral sandblaster. I will definitely recommend the intraoral sandblaster because it's doing a better job on cleaning the preparation. But take a closer look in here. We start to clean the preparation. We are using the intraoral sandblaster, and every time when you want to clean it and clean it well, you'll have bleeding. This is the rule. And the issue then is you have bleeding, you cannot cement. First thing you want to do is to stop the bleeding. We are applying the paste. This is called the gingicap. You have it in the kit. Put it around, ask the patient to bite for 2-3 minutes. You have additional pressure, and then you can wash it, and don't be afraid, use a lot of pressure. There will be no secondary bleeding. Now the preparation is clean. You can cement the crown without any issues. So in this case, we use resin cement, maybe with some glass ionomer, maybe with zinc phosphate cement, which are not that great. You can get away a little bit with biofilm, but keep in mind that you are trapping bacteria into the dentinal tubules in there, and you are trapping bacteria under your crown, which can lead to secondary decay. I think now I will leave my colleague, because he's more experienced than me with intraoral scanners and with prosthodontics, and he will tell you some. He will share with you from his practice and his experience. Christian.
Okay, thank you, Marian. So I will go through some of my cases. Some of them are some extreme situations, like the one that you see here. This is a fresh case. It's a case done today. so I just wanted to add it in the presentation. This patient came into our office and said that it only has a couple of days to stay here, and it has the tooth that was badly decayed. The destruction it's pretty big, and usually in this case I would recommend to do a crown lengthening, and after the healing take the impression, but the patient would leave and come back in a couple of years. So I decided to make an onlay, hybrid composite CAD/CAM monolithic onlay. And for this one, I did the preparation, but as you can see, we can have a lot of bleeding. And the only way that we can register and to be able to scan so deep under the tissue is by controlling the bleeding and the seepage of the gingival fluids. My main way of doing this is by let me go back and show you how I do all the steps in the scanning procedures. So first of all, you can see if you try to scan the area without any the tissue management, the scanner isn't able to scan where the bleeding is so intense. So what I do is cut away the area that is not easy to record, place the retraction paste, and then I need to wait 2 or 3 minutes. But in this time, I continue scanning the rest of the arch and the opposing teeth, leaving the material to act and to create the gingival retraction and to stop the bleeding. And after the 3 minutes, I just come back in the software and cut away the area that we treated with the retraction paste. And then you can see that you can scan very clear, even if the distraction is deep, and the scanner is able to catch all the margins very clearly. After that, it's very easy to mark the margin. So the dental technician has a very clear definition of the margin. So from this situation, it's very easy to be able to create a very well-fitting restoration, even though the margin is almost 2 millimeters in the sulcus. This is another case. The patient wanted to improve the smile. You can see it's a very difficult situation. We decided to make 4 lithium disilicate crowns. In this case, I decided to do a two chord technique, but in this case, I just placed the one chord to be able to prepare a little bit subgingival, the margin of the crowns. And for this kind of procedure, I like to place the first chord to get a little bit of tissue displacement in the vertical way. So when I do the marginal finish, and I always use burrs that are fine grit burrs. I usually use the red burrs, because even if you touch a little bit the tissue, you will not tear so much the gingiva, and you will not have a lot of bleeding. And after you finish the preparation, I just use the retraction paste for a couple of minutes. And as Marian said, you have to wash it very well. So don't be afraid to put a lot of pressure, water pressure. And you can already see that you obtain at least 0.5 millimeter of retraction using the paste. And now it is very, very easy for the scanner to capture every detail, and you don't have any issues with the bleeding or with the seepage. You will get very clear margin, and it is very easy to mark all around the preparation, the margins, so that the dental technician can have a real good representation of the root, so he can make a emergence profile for the final crowns that are very clear. Next. Okay. You see that even if the margins are placed subgingivally by placing the cord, on the scan you can see very clear where to place the margin, so that the dental technician has a excellent situation to do the final restorations. You can see now the printed models with removable dies, and the final restoration is in place with the margins just a little bit subgingival. Another interesting way that I find, and it's very helpful for me when I scan, is to use Teflon tape to be able to, let me go back a little bit, to be able to replace the first cord. So in this case, this patient had some old composite veneers that need to be changed. There are some more than 10 years old veneers. So in this case, we need to make a provisional mock-up to test the new smile. And at the preparation appointment, we need to remove the mock-up. We do this with very fine burrs, not to change a lot of the preparation, and then with the fine red and yellow burrs, we decide to place the margin on the central incisor just at the level of the tissue. But for the laterals, we needed to place the margin more subgingival, because they were teeth that had some root canal treatments, and we wanted to hide the discoloration of the teeth. So in this case, you will see here that by prepping subgingivally with a very fine burr, even if you touch a little bit the tissue, the bleeding will be minimal, and it will be very easy to control it with retraction paste. What I find very useful with this Teflon paste is that it's it's white, and you can use the texture in the optical scanner to see very clear the margin, even if you don't see an indentation in the mesh. So by having a very clear white material around the sulcus and around your shoulder, it will be very easy when you need to place the margin in the software to see the difference between the tooth texture and the Teflon tape, that it's bright white. And after I place one cord of Teflon tape, you just have to inject easily the retraction paste. You can see the I like always to use a retraction paste that is very viscous, because it will push mechanically the tissue, and you can see the pressure that it's created when it's injected. So after a couple of minutes, wash it very, very well to remove any excess material. And now you can scan without any problems, and without any bleeding and seepage. You can see in the right lower corner that when you scan, the bright white Teflon tape, it's very easily captured by the camera. And now when you need to mark the margins, you don't have any doubt where to place it. It's more than crystal clear that where the final crown margin should be. Those are the crowns and veneers on the printed model. At the cementation appointment, I decided to isolate everything with dental dam, and this is the tissue health after the cementation. And you can see that all the margins at below and or at the level of the tissue of the gingiva. And this is the final image. In this case, the patient had 2 implant placed, and it's in the healing period, and the second premolar needs a crown. You can see that it has a root canal treatment and a post and a large reconstruction. And in this case, I decided for this patient to make a vertical preparation and to make a porcelain fused metal crown. After the preparation, we have a lot of bleeding, and I try to scan. I do this scanning just to show you that you are not able to make the scanner catch any detail in the area that is a lot of bleeding. I use the retraction paste. I leave it for 2 minutes. I continue with the scan, scanning the upper jaw and the lower jaw during this time. So after that, the scan, I just cut away the area that was captured with the retraction paste. And during this time, my dental assistant will remove any excess material. And very quickly, you can see that you have a very clear margin, and you can use the intraoral scanner without any issues. In this case, I like to do the preparation of the vertical preparation. I don't want to go more than 1 millimeter in the sulcus, so we don't have to do any kind of biological width violation here. If I stay 1 millimeter, maximum 1.5 millimeter, I'm sure that I will not create any periodontal issues for these teeth. You can see that very easy. You can place the margin for the final crown. I don't want them to be very close to the registered margin, so I can leave it a couple of 0.1 or 0.2 millimeters away from the tissue, because the tissue will heal and everything will be closed very, very good. And in this case, we have a 30 years old patient that came with a lot of attrition. We decided to do digital mock-up with a new vertical dimension increased. We have here the mock-up done in Exocad. In this case, I always prefer to make the mock-up a little bit buckly to make it a little more bulky, let's say, because I don't want to remove any kind of or to remove minimum enamel. So I always try to add more material than I need to remove. This is the amount of material that we plan to add. We decided to transfer the mock-up intraorally using access crown. You can do this very easily by printing the mock-up, take an impression, and then just inject the provisional material. In this case, I didn't etch and bond and use any bonding on the tooth because I just wanted to be locked mechanically on the teeth. Okay, so place it in the mouth, leave it for 3 minutes. The material has a very small contraction that it's allowing the material to stay locked mechanically. And by doing this mock-up, you can talk to the patient and have an idea about the shape and how he feels with the new vertical dimension. And this is very helpful in choosing the right shape and to understand what are the main requests of the patient. Next slide. This is after we did the same technique on the lower ones. We did the groups for the preparation. So I mark everything through the temporary material just to remove the right amount of enamel. In this case, I decided to place a very thin cord, a 000 cord, to stay away with the burrs from the tissue. The plan for this patient is to leave the margin supragingivally. I don't want to go under the tissue with the restorations. With the cord in place, we inject the retraction material, leave it for 2 minutes. And you can clearly see also in the picture that we have a lot of retraction. We scan everything. After that, we have the margins placed so that the dental technician has not wonder if he put the margin in the right place. I always like to do that myself. And since I work with optical scanning, for me, it is a very important step because if you have something that you need to change, it's very easy to see, and it's very easy to cut away that area that you need to modify and then scan it again. Here we have the veneers on the printed model. We do the same technique on the lower ones. And then at the bonding procedure, here we decided that because usually it takes about 10 days for the final veneers to be ready, we decided to spot etch the teeth, and when we make the provisional veneers after the mock-up, I want them to be spot etched, just to be able to hold them in place as long as the dental technician is working on the case. These are the provisionals. And here it is at the try-in. I like to check the fitting with the magnification to see if everything fits very, very well. And we do the bonding procedure and apply the veneers. Okay, let's see. This is immediately after the lower veneers were cemented. So for the final words, I can say that in my practice, since I started to do optical impression, I like to use all the techniques. So I'm not saying that you should avoid using the cord, because the cord is essential in some procedures. I'm a big fan, and I used a lot of cord before, and I'm still using the cord. But really, for the scanners, for the optical scanning, I always use a kind of retraction paste, because you can get a very clear field very easily, and it's very pain-free for the patient. If you require to place the margin subgingivally due to the discoloration of the teeth, or just to have more ferrule, using a cord is for sure necessary. There are also other techniques like laser or electrosurgery that you can use to manage the tissue. But for me, I find it very easy, and also it's not expensive to use the retraction paste in most of my cases. Marian, if you have
Yeah.
something to add.
I want to ask you if you have any questions, and I have a few right now from you. So if you have any questions regarding the gingival retraction, tissue management, or intraoral scanning, please type it in a Q&A chat box. The first question is from Chris, and it is like that. Would you suggest having the patient bite down on a cotton roll to further push the paste into the sulcus? The Traxodent kit comes with cotton rolls. So usually, I think 99% of the time, we will not use compression caps, something like gingy cap or compre cap, or you name it, or cotton rolls. Just leaving the paste in place for 2-3 minutes, it's enough in 99% of the cases. Sometimes in difficult situation, when the margin it's really deep, or the gingiva is really inflamed, and you want to totally control the bleeding, and you need additional pressure, you can use the compression cap, the gingy cap, the any type of compression, even a cotton roll. As you saw, when you're applying the retraction paste, sometimes if you are not happy how the retraction paste was placed, never use a spatula or a metallic instrument, because it will stick to that. Always use cotton rolls, and we are using cotton rolls just to push with the cotton roll the retraction paste deeper into the sulcus, and make an intimate contact with the gingiva. But we are not placing the cotton rolls in place for 2-3 minutes for the patient to bite on them.
I sometimes use the cotton roll if I have a lot of bleeding. Sometimes it happens that you inject the material, the retraction paste, and you see some bleeding that comes around the material. And I like to use the cotton roll just to absorb the excess bleeding or the excess moisture, and then I like to leave it like this. Usually you'll need some kind of compression cap if the retraction pace is not viscous enough. If you have a viscous enough material, it will do the job by itself. So it's not necessarily required. I rarely use the compression cap.
One more question will be, sounds like this, the veneers look great, but I wonder why the diastrema wasn't closed. I want to tell you that was the decision of the patient.
It was a preference of
said,
the patient, yes.
Yeah, because that bothered me too. And I asked my colleague, why the diastrema? I said, no, the patient want to keep it. He said, this is his charm.
For me, it's not an issue. If the patient want to keep it, that's why I do the mock-up, and that's why I do a lot of trying. That I like a lot of the time to do some to take photos and make a digital smile design. Because it's very important to understand what the patient wants, not necessarily what I like or what the dental technician thinks that the shape of the teeth should like. So maybe sometimes I do 2 or 3 mock-ups and transfer it to the patient just to be able to understand what are his needs, and if it's possible to make every modification that the patient needs, because sometimes they want something that is not possible.
Other question will be, what the resolution of the scanner? I simply don't know the scanner. I can tell you that we are using its Medit i500. We use also the OmniCam from Sirona in free shape. We have in test right now one from Shining, if you are familiar with this brand. But I don't know the resolution. The scanner that we use here, it's a Medit i500.
Yes, usually what the resolution of the scanners, it depends very much on the type of the preparation that you use. There are some scanners that they are very accurate for prosthetic work on teeth, but if you need to scan a full arch on implants, they are not recommended, because when you start to scan from one part of the mouth and you reach the other part of the mouth, usually there will be some differences in the scanner. So it depends on what kind of restoration are you planning to do. If you want to be able to scan full arches for implants, then maybe a 3-shape or OmniCam scanner, it will be the one that you have to choose. That it's more expensive, of course.
Other question will be, usually you prefer supra or subgingival preparation?
I always prefer supragingival preparation, because it's much better to leave the margin in the enamel. It's much easy to see. It's much easier to register everything, but most of the time you're not able to leave the margin supragingival due to aesthetic reasons, or to do with badly destroyed or decayed teeth that are that they need to be restored subgingivally, as you saw in my first case. So you have to adapt to the situation. If you can stay supragingival, you have to stay supragingivally. It also depends on the material that you choose to use for the final restoration. If you do a porcelain fused to metal crown, for sure you have to go a little bit subgingivally to be able to mask the gray area of the metal. If you go all ceramic, it's very easy to do supragingival crowns. But it depends on what the patient wants, what he can afford, what is the situation in with that tooth.
So if you are, there are no more questions, we want to thank you for being here with us. I hope that was helpful, and we give you some nice, maybe useful information for our practice. Of course, we we need all the time information, and we need to learn from each other to get better. Thank you so much.
Thank you. It was a pleasure to be here.